After a left ventricular assist device is implanted, the patient's recovery hinges on the right ventricle's ability to accommodate the sudden shift in mechanical flow. Predicting which patients will develop right ventricular failure, or RVF, is a complex challenge. Traditional clinical population statistics often lack the resolution required for individualized precision. To address this, researchers analyzed a dataset of 327 patients, evaluating 13 distinct preoperative clinical features to predict RVF before the first incision is made. Standard clinical models typically rely on logistic regression to forecast these surgical complications. In this study, the baseline regression model yielded an area under the curve, or AUC, of 0.80. Researchers then compared this baseline to ensemble learning, an approach that aggregates multiple algorithms to achieve higher predictive stability. The ensemble approach demonstrated a measurable performance gain, reaching an AUC of 0.888. However, high accuracy alone is insufficient for clinical adoption if the underlying logic of the model remains opaque to the surgical team. To provide this necessary transparency, the team utilized SHAP values, a mathematical method used to calculate the specific contribution of each clinical variable to the final prediction. This combination of predictive power and statistical interpretability provides a framework for integrating machine learning into preoperative clinical workflows. Evaluating the model's reliability requires an examination of the data pipeline, starting with how the raw clinical inputs were processed. The study began by splitting the patient records into distinct training and testing cohorts. The dataset contained a significant class imbalance, 255 negative cases of RVF compared to only 72 positive cases. Without adjustment, an algorithm trained on this distribution would likely bias its predictions toward the majority class to reach an artificially high accuracy score. In a clinical setting, this mathematical bias would result in a high rate of false negatives, potentially missing the very high-risk patients the model is intended to identify. To mitigate this risk, the researchers applied oversampling to the training data. This process generates synthetic, mathematically plausible data points for the minority class until the positive and negative cases are balanced. This adjustment ensures that during the learning phase, the model is forced to prioritize the detection of true physiological risk factors. The predictive model was then further refined through five-fold cross-validation. By repeatedly testing the algorithm on different subsets of the data, the researchers confirmed the model was identifying generalizable patterns rather than overfitting to the specific training samples. This rigorous pre-processing ensures the resulting predictions are grounded in the actual physiological drivers of RVF. Beyond the training process, we must look at which specific variables the model identified as the most significant predictors of failure. We assess this through Gini impurity, ranking variables by how effectively they help the model categorize outcomes across the study population. The two most influential features identified were the CVP to PCWP ratio and the pulmonary artery pulsatility index, or PAPI. Both are established hemodynamic markers of right heart function, which aligns the model's logic with standard clinical understanding. However, because both metrics relate to right heart pressures, it is necessary to determine if they provide redundant or unique information to the algorithm. To test this, the researchers generated a Spearman rank correlation matrix. The intersection of these two variables shows a correlation score of -0.75. This strong inverse correlation confirms that while the markers are related, they provide distinct physiological data, justifying the inclusion of both in the final model. These global metrics provide a baseline for trust, demonstrating that the algorithm is anchoring its predictions in verified hemodynamic realities. While global importance proves the model is logical, clinicians require an explanation for the risk score assigned to an individual patient. The SHAP plot provides this granularity by mapping variable impacts for every patient. On this plot, 0 is the baseline risk. Dots to the right increase RVF risk, while dots to the left indicate a protective effect. The color gradient indicates clinical value. Red points represent high measurements, and blue points represent low measurements. For the CVP to PCWP ratio, the high values, the red dots, consistently drive the risk profile significantly to the right. This visualization reveals the specific physiological drivers behind a single patient's preoperative risk assessment. If a patient has an elevated CVP-PCWP ratio, the model assigns a positive SHAP value, adding directly to their individualized risk probability. Other factors like PAPI or BUN measurements generate their own SHAP scores, which add to or subtract from the total until a final personalized risk percentage is reached. These values provide the underlying physiological rationale for each prediction. Instead of an unexplainable number, the surgical team receives a ranked checklist of the exact parameters that are driving a patient's risk profile. The performance of a preoperative algorithm is ultimately validated by its ability to predict survival outcomes in the years following the procedure. Researchers evaluated this by comparing Kaplan-Meier survival curves for patients classified as high versus low risk. Outcomes clearly diverged shortly after implantation. At 3 years, the low-risk group maintained a 90.5% survival rate, compared to 75.3% for the high-risk group. By addressing data imbalances and utilizing ensemble learning, the model achieves a level of predictive accuracy that exceeds traditional statistical methods. When high predictive accuracy is paired with the transparent, feature-level evidence provided by SHAP, these models offer an objective framework for refining preoperative clinical decisions.